on that diagram, maybe I'm just over reading it, but the thinnest line was between subspecialty care and geriatric care. Was that, there's some hidden?
Well, it was.
I know my own interpretation.
Yeah, it's my first attempt at trying to figure out what I do, and I, as the latest person to enter the game, I feel that oftentimes what I'm doing is modifying or interpreting or changing the relationship between the already existing providers and the primary care provider. I'm prepared to change this this model and almost certainly will, but that may reflect the fact that I see myself in many ways as a modifying presence rather than one who's presenting an entirely new set of meds or an entirely new organ to deal with.
Well, I think one of the points that you brought up is that we do identify important issues which the subspecialists don't necessarily, may not be aware of. You can't send a consult to somebody about gait. That would be under our purview. So I think what we have to do, I know I'm preaching to the converted here, but just in terms of our interaction with subspecialty care by definition is very organ or disease focused, whereas from a geriatric perspective, we sort of step back and look at the individual in their environment, and that's a different approach than just adding another layer of diagnosis.
Yeah, I'll fully admit I'm a doctor, not an artist. So I think we're saying the same things. There are sometimes when I talk to residents or medical students, I will say that regarding a patient that we have exactly the same problem list, but that my problem list is your problem list upside down. And that's where I think the modification and the adaptation comes in, that no, you can't give these 5 medications, or no, you can't be entirely focused on this organ because there are implications for the rest of the body. And I have a feeling we're saying the same thing. I just haven't figured out a way to represent it.
Number 2, please.
I think.
Is there a number 1? Sorry, I can't see.
Yeah, so I come from the UK, so there may be some slight differences, but a kind of 2 related questions. So you briefly mentioned your normal geriatric practice, I think, and that tends to be the sort of very geriatric patient. So I just wondered, are you also seeing some of those from the HIV who have HIV, or is this a rather currently less dependent population that you're principally seeing? And then kind of related to that, you mentioned the establishing and resetting of priorities, and certainly as a non-geriatrician, that's something that we really value geriatricians for. And I just wonder if you could expand a little bit on, or give some examples of how you've done that. I think that ties into the last point here about, what you can offer over and above subspecialists, doesn't it? But
the answer to the first question is yes, we have. I depend upon referrals, obviously, for those who have HIV, but some of them have been in their 70s, and I think I've seen one in their 80s. So absolutely, we have very geriatric by any sense of the word people with HIV. What I'm I think reflecting on is that in my own mind, what is the kind of care I want to give for someone who is, again, aging with HIV as opposed to aged with HIV. I'll give another story. I was talking with someone who was younger about retirement, and on the next visit he had told me that he'd enjoyed the talk, and one of the reasons he had was because I reminded him of his mother, And I can guarantee you, in almost 30 years of geriatric practice, that has not been said to me. And so some of it is my learning what geriatrics means and how I can be a geriatrician or as we call it, an aging specialist. There are 50-year-olds who do not want to see a geriatrician, and I'm sometimes referred to as the aging specialist. I have to learn how to counsel people that way. In terms of resetting priorities, I think I'll give you a more general observation that our psychiatrist once said to me was that, again, our HIV providers, as I suspect most of you have been in this business, have aged in this business for a while and have been working with your patients perhaps for several decades, or if not more. And the psychiatrist said that one of the things that I was doing was giving people permission to let go. And so oftentimes in the discussions about goals of care or discussions among the group, that recognizing that someone really is aging and really is impaired and cognitively has lost a lot of function, sometimes just saying that, think about where this person is and what's going on. It's time to begin to think about being less aggressive. That's not happened a lot, but it's happened enough that it struck me as something that I've brought in that I wasn't expecting to.
Go ahead.
One of the best and perhaps only interventions we've been hearing about for a lot of the comorbidities we've been talking about the last 2 days is exercise. So as a geriatrician, what resources do you have, or if you don't have them, do you think there need to be, to get people into exercise, to pay for a gym membership, physical therapy consults, other supportive services to keep people exercising, to keep them healthy?
Dr. Giraldi was talking about giving us all his patients Fitbits. And we're trying to figure that out. The simplest thing is physical therapy because it is paid for, Medicare pays for it. The program offers yoga, and I've wanted to find a way to get Tai Chi in as well. There are lots of things that I would love to do. At the moment, the simplest thing is actually to do what insurance pays for, but it's not enough. And that's why, as we're exploring what we do now that we're a year in, is exactly that. I'd like to do the same thing for nutrition. How in the world do I teach people how to cook better, how to eat better? There's so many health-related things that I would love to bring into the clinic, but I, for the life of me, can't figure out how to pay for them.
Number one, please.
Yes, thank you so much. I appreciate your presentation. My question is, now that HIV has been in the category of a chronic disease, do you see that there's a need for instance, when there's a geriatric conference, to have HIV and aging on that agenda, and vice versa? It's almost like there's a stammering to get it together, but a lot of folks still don't realize that it's a chronic disease and chronic inflammation. I know there was a Geroscience Summit about the drivers of aging. They looked at diabetes, cancer, and HIV, and I thought that was phenomenal. But we need more of this to happen when there are geriatricians or gerontologists coming together.
Absolutely, and I think that there's a younger generation of geriatricians who are going to drive this. Both the American Geriatrics Society has an interest in this, and this whole two-day conference, you've seen articles published in Aging and Journals of Gerontology. So it's not where it should be, but I don't think there's any question that we need interest groups within our own specialties to grow. They're there, but they're small, and we've got to work on that.
Last question, please.
Hi, thank you for your talk. Very fascinating and very important topic. And I'm wondering, many of us, when we trained as HIV specialists, it was a more complex type of care that we had to deliver in terms of antiretroviral therapy, opportunistic infections. And now what we find is that we're the HIV piece of the care that we're delivering is perhaps the simplest piece of it in many ways. And we find ourselves sort of delivering geriatric services without training in geriatrics or without sort of approaching it from the same type of perspective. And I'm wondering if perhaps rather than the HIV specialists being the primary care providers, perhaps we should be the consultants and the care should be delivered sort of from the geriatricians for many of these patients who are in their even 50s and 60s rather than the other way around.
I think there are multiple models, and that certainly is one. The problem is there aren't a lot of us either, and I think you're bringing up a really fundamental point, which is HIV care has gone from being a subspecialty care to primary care and even geriatric care. Something that I thought I had would not see much again, which is AIDS and HIV is now a real part of my life and what we counsel about. Who does it? And I don't know the answer. I think what's going to happen is that there will be multiple models of care. And the question is going to be, how do you make sure that all the components are there? And is your clinic going to be a geriatric clinic with an HIV specialist managing the medications? And is our clinic going to be an HIV clinic with a geriatrician helping with the geriatric issues? I suspect there will be multiple models. I hope there will be multiple models, and those who are expert at the kind of research may be able to determine which one's the best. We've got to start it somehow.
Okay, I think we're going to go into our...
I have one last question, Julian. So you mentioned access to geriatric social services for HIV-infected patients, which is obviously critically important. Do you find that the existing geriatric social services are adequate for HIV-infected patients, or are there needs beyond what already exists?
There are certain limitations, some of which are age limitations. The Aging Services Network generally doesn't start till 60, unless you're in a PACE program, which starts at 55. The geriatrics programs do not know what to do specifically with people who have HIV, and I think that as the feds recognize that these systems have to be merged, the no wrong door model of just combining these loci of care is the way to go. What I will say is that perhaps one of the advantages of having the different networks talk to each other may be to learn from each other's models. The geriatrics models, for example, NORCs, naturally occurring retirement communities, villages. These are programs which, if redesigned by people who understand HIV, could take the best of the geriatric model and the aging network funding, but create something that was more tailored to the needs of people with HIV. I'll make one other comment and then finish, and that is that I think people are becoming at least a bit more sophisticated about LGBT needs. An example is River Spring, which was the old Hebrew home in New York City. They now have an adult day program at SAGE, which is the LGBT senior center in New York, and they are establishing a unit in Hebrew Home, a nursing home just for LGBT. That's a step, at least in recognizing that individuals have needs and have fears and want to be comfortable. There's another level, which is making these things truly sophisticated in their understanding of the needs of people with HIV. But they're starting to think about it. We just have to find ways that they talk to each other.
And Last question. Do you feel like the emphasis in getting new services should be done at the local level, the state level, or the federal level, or a combination?
Yes.
Yeah. I mean, what do you think is the most effective way to do it? I mean, it seems like these services are administered in different ways.
They are. I mean, I think, again, for the patient, it's just, you know, this is what's available in your neighborhood. Try it. But this is federal. This is finding ways so that these programs are supported and that there are opportunities to create demonstration projects that meet specific needs.
Thank you very much.